So on January 9th, Medtronic released a press release with the results of the Simplicity 3 trial. What did that show, Barry?
Well, what they indicated in the press release was that they had sufficient data to look at the primary endpoint, and that the primary efficacy endpoint was not made. That's the specific language that was used. However, the safety endpoint was made. So there are two important conclusions. One is that this was a device versus drug trial, essentially, because it was a sham arm. And the good news, so to speak, was that there was no additional risk or no extraordinary risk associated with having the device as part of this trial. The bad news was that the data showed that there was no benefit to the study technique, which was the renal denervation. So, and that's really all we know at this point. Medtronic made a decision to make that public and to take certain actions where they stopped all their research into this space while they had a chance to analyze the data to determine what direction they were going to go and try and learn from the data.
So it's important to emphasize to our listeners that this is a press release. This is unpublished data. It's going to go through formal review and at some point appear. And many are going to wonder, actually, why this press release was done. And as a publicly traded company, there's a fiscal responsibility about reporting this in a trial as big and as important in this market, right?
Once Medtronic became aware of certain information, they have a responsibility, both fiduciary and from a public health point of view, to act on it. What they didn't have a responsibility to do was to release all the data. And the reason is they're trying to protect the scientific integrity of that data, to allow it to be peer-reviewed by physicians, people in the space, and go through a traditional peer review, which would have been jeopardized had they just started releasing data to the press.
And they fully are going to follow all these patients through to the completion of the study as planned?
Yes, yes.
So I think some of the questions everybody's wondering is, what has this done to the field? And there are a number of immediate, easy questions that come up, which is, are some patients different that were studied? Now there are other populations, and are devices, or might devices be different as well? So maybe we talk about devices first. Was this the be-all and end-all in approaches to RDN, and is this ended if this is negative?
I think it was pretty apparent to everyone this device isn't the end-all and be-all. Medtronic, I'm sure, knows that as well. But as you know, when you're trying to get a device approved, you have to stick with a certain design. You have to make a commitment and just see it through, and that's the decision they made. The question is, how important is that? And I don't think anybody knows the answer. In other words, are future generations of devices head and shoulders better? Who knows?
There are different ways to deliver energy. There are ways to be cooling blood vessels as well. There may be uniformity issues that may or may not be important. I think there's still a lot of questions in development that, as you say, come with an early design and a vanguard design as well. We've seen that in almost every endovascular product that we've seen, from nothing that we use as an endovascular aortic graft resembles the very first signature pieces, right?
Right, and even Medtronic themselves have a development pipeline, to improve on the technology, to make sure the burns are more effective, make sure the time of the procedure is reduced, and so on. So there's, as Fritz was saying, this is early stage technology. The amazing thing was how effective it seemed to be in all those early trials. And so that offered a great, provided everyone with more enthusiasm about taking things to the next level in terms of technology.
Unbridled enthusiasm.
Unbridled.
Yeah.
Unbridled. And I think, really, for those who may not be familiar with this, there's a lot of business issues surrounding this whole area because of the amounts of money being paid for companies and things like that. And the reality is that, that really complicates their ability to look at things scientifically with a clear mind, because part of what was driving this was unrealistic expectations. And our European colleagues found out very quickly as the devices became available to them in the commercial space, and as with other devices where you take the device and you start using it off-label for patients that may not be included, they found pretty quickly that when you started wandering off-label with this technology, you were not getting very good results.
So it is approved and widespread in many countries. In North America, it's used in Canada. It's approved in Europe care to speculate whether this press release and this information is going to slow any of the clinical care as well trials outside of the U.S.?
Well, I think it's a little too early to tell. And at ICET this week, we heard from our European colleagues on the panel where we discussed this today, and most of them said at this point, no, that they know what they're seeing in their own patients, that they know what they're seeing clinically, that the data that they have supports what they're doing clinically. And the other thing that's important to understand, that at least within European countries, as Mark Sapoval said today, it's not the United States of Europe. Each country is quite different, both in terms of what the availability of renal denervation technology is and whether governments pay for it. So at least the three Europeans that were on our panel today all seemed to indicate they didn't see much change. Now,
the Denervation trial is going to continue. That's the French trial. And there are other prospective trials that are underway that are going to bear additional additive data.
Right. What has happened is other big companies that are in the field have halted or suspended either their trials or their intention to do trials pending the release of the actual data. Because I think no matter how you speculate about the results are, everybody, before we move forward, needs to know what happened in Simplicity 3, Hypertension 3. We need to know.
So you're pointing out that the cost of carrying out this research is enormous, and we should probably touch on why this is very different than perhaps some of the other trials that we've seen.
Yeah. Would you like to comment?
Well, I think that the number of device trials that have involved not just a control arm, but actually a SAM surgery arm are extremely rare, right? You can count those on one hand, and so that's very unique. And I think that because there is such a standard of care with medicines, that you had to do it that way. So obviously that's the benchmark. That's all the subsequent trials in the United States are going to have to rise to, and that's a very, very expensive proposition, no question about it.
And also just to add on to that, this trial had a huge amount of work before patients even got into the trial. And from a trial design point of view, and this relates to getting the right patients. And early on, the original company, Ardian, discovered that about 30 or 40% of patients that had been identified as having resistive hypertension basically weren't taking their meds. And this is a very common problem in people who work in the field of hypertension, which is just non-compliance is the most common cause of resistant hypertension.
Even bed rest in the hospital improves blood pressure.
And so if you put a patient like that in a clinical trial, it's going to confound the data. And so this trial had a very rigorous, several months roll-in phase where patients had to be monitored. They had to write down for 2 weeks both their blood pressure and that they took their meds at certain times and keep logs. Now, that's pretty rigorous. And that is a lot of work for clinical research coordinators. And these were patients who were not officially even in the trial. They had to go through this. So it was part of the screening process.
This was auditioning for the trial.
Yeah, and it created huge budget and work problems for many academic institutions and research programs. So that's one issue. Also for interventional radiologists who were involved in this, it created logistical issues in terms of how you manage them, how you handle those patients, and so on. So I think one of the things we're going to learn from all of this is how to make sure that we have patients that have true resistive hypertension that enter the trial.
So as we start to draw to a close, I had a couple more questions, which is, given these findings, what's it going to take to reboot this research in the U.S. specifically?
Well, what's interesting is this is, as you said, Dr. Katz, it's not really a device trial. This is a medicine trial that we happen to be testing a device in. So it's quite ironic that here's this major trial where really the medicine, although well monitored, wasn't necessarily controlled. The choice of medications, what the first-line medication is going to be, et cetera, wasn't necessarily controlled. So that's probably going to have to take some careful thought by whatever company decides to pick this up, don't you think?
Yeah, absolutely. This medical arm is kind of loosey-goosey, because for us in the device world, we tend to be much more black and white about things.
It's a binary
approach. And the control of medicine, when you actually read through the hypertensive literature, they're so paranoid, the hypertensionologists, about whether the trial design actually includes the patients that don't take their meds, that some people only accept witnessed taking of the meds.
Absolutely.
And there are trials that compare the outcomes of trials when there's been a witnessed taking of medication, so-called resistant hypertension. And if you have witnessed taking of meds, the incidence of resistant hypertension drops about 30 or 40% in the population. So,
and what disease is there where a little bit of exercise and diet has a bigger impact than in hypertension, right? So you put somebody in a trial, and 6 months later,
your blood pressure is lower
can.
with exercise. You may still be obese, but
Yes,
your blood pressure
but
drops
you were
by
working
30.
harder at being,
That's right.
being healthy.
So as we wrap up and perhaps look outside of renal denervation for control of resistant hypertension, there have been some suggestions that this may have an effect on left ventricular hypertrophy, on diabetes, on sleep apnea, some other conditions. Some comments as to where these might go?
Well, I think there are a couple of issues in this area. One is that we're learning more about the sympathetic nervous system and its linkage to the cardiovascular system. And so for most of us, that involves a lot of restudying and relearning of physiology that we've ignored for whatever, 20 or 30 years, depending on how old you are. There's no question when you look at the sympathetic nervous system and how much it touches, if you can interfere with it, you can affect things, as you mentioned, particularly diabetes, sleep apnea, heart failure, left ventricular function, a number of other things. We've encouraged the SIR, and in fact in the SIR task force on this subject, we've sort of changed the name to sympathetic denervation, and because it's much broader also. So in addition to the other systems, there are other ways of creating denervation through carotid stimulation, through percutaneous ablation. We've done percutaneous sympathectomies in the past for lower legs. So those are being explored, and I think it's going to be an important area of research and development for interventional radiologists moving forward.
Fritz, any closing comments as we wrap up?
I think the research opportunities for interventional radiology are outstanding in this area. When we think about the sympathetic, how little we understand the sympathetic system, let alone how to manage it and denervate it, is quite an opportunity. It's really interesting.
Well, on behalf of the Journal of Vascular Interventional Radiology, I want to thank you both for being here, and thank you for taking the time to listen to this podcast.